So welcome again to this session on public health applications of remote sensing. I'm Maggie Hurwitz from NASA's Goddard Space Flight Center, and I want to welcome you along with my co-conveners, Brian Duncan and Asafa Nyamba, who unfortunately couldn't make it today. So I'll try to do my best to ask all of the questions they would have. We're going to have 4 short talks today, and then the speakers are going to come back up here and join me for a short panel to discuss the geohealth field. So first speaker is Ken Linthicum. And I should have said our first couple of talks are going to focus more on vector-borne disease and using geospatial data for those problems, and the second 2 talks are going to address air quality and air pollution. So Ken, over to you.
Thanks very much, Maggie. So what I'd like to do here is give you a brief summary of how we can use global climate to predict and to forecast some vector-borne diseases. Particularly, I'll talk about Rift Valley fever virus. Can you hear me in the back? Yes? Oh, you can? Oh, great. Anybody ever heard of Rift Valley fever before? Radina, I know you have. Okay, so briefly, a few topics I'll hit on, again, very briefly. Just a little bit about a background on Rift Valley fever. It's primarily a sub-Saharan African disease, also occurs in the Middle East. It's a zoonotic disease, meaning it's a disease of animals principally, but it also affects people, and it affects people, like shown in this picture, who live in close proximity to their animals. So when their animals get sick, they get sick. And the reason they get sick is because some reasons I'm going to tell you in just a moment. It causes 100% abortions in cattle, sheep, and goats, essentially. It makes adult animals sick. It has serious human consequences, including hemorrhagic disease. One thing we found out more than 30 years ago is that outbreaks are closely linked to heavy rainfall periods. So this shows rainfall from 1950 to the early 1980s. And whenever there's excess rainfall, as indicated by the positive areas here, there are large outbreaks. But in between times, when rainfall is either normal or drought, there are not large outbreaks. But what happens when it rains is areas flood, like as shown in this picture. This happens to be in East Africa. And when that floods, eggs of mosquitoes that are laid in the soil and have been there dormant hatch. And mosquitoes like the one shown in this picture come out, and they're already infected with the virus. So they start an outbreak. Now, if areas remain flooded long enough, we can sample and we can find the larvae, and these mosquitoes, Culex mosquitoes, start developing, and they provide excellent secondary vectors. We can also sample for adult mosquitoes, and we find other ones there like Anopheles mosquitoes and mosquitoes that transmit malaria, but they don't transmit Rift Valley fever. Other ways you can get Rift Valley fever is by handling animal tissues or abortuses, or just harvesting animal products. If they're infected with the virus, people can become infected. So we've worked out over a number of years, a life cycle that involves an endemic cycle shown on the left here, and then also an epidemic cycle. The difference between the two is just depends on how much rainfall occurs in an area. As I showed you before, a lot of rain, you end up with epidemic cycle. The virus comes out from eggs that are laying dormant in the soil and infect animals and people. Another thing that we discovered was that its outbreaks are very closely linked to ENSO events. So here from 1950 up until 2010, every single Rift Valley fever outbreak has been linked to an El Nino event, but not every El Nino results in a Rift Valley fever outbreak. there's one other factor that has to happen, and I'll tell you about that in just a moment. So we look at global climate phenomena, and since it's closely linked to ENSO events, we're very interested in El Nino, when it's warm here. And then the second part that has to happen is warming of the Indian Ocean in this location. This is sea surface temperatures on the top, and then outgoing long wave radiation on the bottom. So here, warming of the ocean indicating in OLR data, heavy precipitation, heavy convection, also correspondingly heavy convection in the Indian Ocean. So if you have an ENSO event and you have simultaneous warming of the Indian Ocean, which happens together, then you're at risk of a Rift Valley fever outbreak. In fact, one will happen almost certainly. One other thing we found is during ENSO events, there's a close linkage between temperature of the ocean and rainfall. And here, a person's correlation coefficient data shows that. And basically what it's showing is you get warming here, you're going to have close correlation with rainfall, heavy rainfall here in the Pacific. There will also be heavy rainfall in the Horn of Africa, and also in the southern tier of the US, of course, and southern South America. But then on the other side, closely correlated negatively, is areas like Southeast Asia and Southern Africa. There you find drought during ENSO events, and that causes other vector-borne diseases to be enhanced, and I'll touch on that in just a moment. So remote sensing capabilities we've used, we started doing this type of work actually in 1980 with Jim Tucker at Goddard. We continue to work with him and his group, but using all the newest remotely sensed data sources. So we have this ability to both look at the ocean, of course, and the land. Vegetation on the land, of course, is also key to inferring rainfall events. So what we have developed is an actual operational model that is published on our USDA website, where we can actually show what's going on globally, ocean-wise, also vegetation development in Africa, and eventually produce risk maps as shown here. For example, this produced in 1997 with the red indicating elevated risk for Rift Valley fever. And I'll show you just one example. So this is sea surface temperature, Indian Ocean, and Nino 3.4. And whenever there is a simultaneously increase in those temperatures, outbreaks occur. In 2006, we saw a similar kind of concurrence occur. This is what it looked like. We saw warming of the Indian Ocean as well as the Pacific, increased precipitation. So we actually published and put out warnings through our international partners, with WHO, FAO, other US government agencies, warning of this. FAO actually put out an alert. So for the first time, this was actually put out. What happened was shown in this slide, a number of human cases. These are all human cases shown here. Of course, this is an animal disease, so that means there were tens of millions of animals dying. This graph just briefly shows actual human cases in Kenya, Tanzania, and Sudan. The dashed line here at the beginning of those cases indicates the first case. So that's the first case in Tanzania, the first case in Sudan is right there. This dotted line is actually when our warning came out. So you can see, you probably can't see, but the warning came out 3 to 5 months before the first case was actually documented. So it gave a lot of warning. This slide shows spatially in red where our risk areas were delineated and put out. The dots indicate human cases, and spatially, we were also quite effective in identifying where they were going to occur. So both when they were going to occur, and then so the next step is, so what do you do about it? So we have this cycle I showed you just a second ago, in this cycle, I've put in here 1x, 2x, and 3x. These are parts of the cycle that you could potentially interrupt through different techniques. And if you could interrupt the cycle in the beginning, like for example, we can put out the warning way up here, and if you could do vector control, you could do max vaccination of animals, you could theoretically stop an outbreak from actually happening. So this is a tabular form of what I just said. Up until recently, I thought that actually vector control might be the most effective technique. So let me go on and talk about what happened in 2014, 2015. So as the El Nino developed, again, warming of the Pacific, a warming eventually of the Indian Ocean, we put out warnings. This is OLR data just showing convective activity. And then just a table here comparing it to 2006 to 2007. So it was very comparable, perhaps even a little stronger. So just looking back at what I showed you again about this linkage between ENSO events and precipitation and drought in the world, based on this, we knew that there was going to be a drought in northern South America, the Caribbean, drought in Southeast Asia. This meant that there would be high likelihood of having dengue and chikungunya transmission in these areas, and this is based on work I haven't showed you, but which we have developed. And then also high risk of rainfall in the Horn of Africa, potentially leading, we thought, for sure, to Rift Valley fever. So this is actually the warning that went out. These are the diseases shown here at the bottom that we thought would likely occur based on that linkages that had been discovered. So, and so this is actually what did happen. So these are cases, chikungunya happening in various places. We were very accurate in all of these diseases, with one exception. Zika came into South America. We didn't anticipate that, but I'll talk about that in just a second. But the one glaring thing that didn't happen was there was no Rift Valley fever in the Horn of Africa. So where did we go wrong? I wasn't too sure. So I went to areas that we know had heavy rainfall, and the habitats had flooded. The mosquitoes were out. Here they're feeding on me. But the animals were okay. So what happened? Well, what happened was our warnings went out, and in this case, the government of Kenya, the president of Kenya, the minister of veterinary services in Kenya, vaccinated repeatedly every animal in the country. And so what that did was completely prevent an outbreak from happening. So phenomenally, could have used vector control after our warning here, but they didn't. They used vaccination, and vaccination stopped the Rift Valley fever outbreak. So here, just looking, just want to go back to this one area, looking at what we had predicted, that we thought chikungunya and dengue would occur in Brazil, and that was based on this elevated, or I should say, high temperatures and drought that was occurring in South America. This is where Zika eventually occurred, however. It turns out that Zika, the transmission ecology for Zika, for dengue and chikungunya are very similar, transmitted by the same mosquitoes, and the viruses are very similar between dengue and Zika. So this is what it looked like at that time in 2015. This is where Zika was occurring, and that's the heavy drought appearing there in South America. I'm going to just change a little bit here, but in 2015, end of 2015, end of 2016, there was an outbreak of dengue on the island of Hawaii, and this graph just shows, I mean, this figure just shows where the cases were occurring. And then this is what actually it looked like in Hawaii during that time period. Very elevated temperatures and a drought period conducive to dengue transmission. So a big impact there. Also occurring in the world at the same time was this in California. Up until 2011, Aedes albopictus had never occurred in California. It appeared, Aedes aegypti had never been there, and first detected in 2015, and it's gone wild. These are all the places Aedes aegypti occurs. Nobody thought Aedes aegypti would live in the California arid environment. And so this is what it looked like as you go through elevated rainfall events associated with the El Nino. So in conclusions, I think that we can use El Nino to look at vector-borne diseases, and we can use those actually to give out warnings and perhaps in some cases, in the case of Rift Valley fever this past year, actually prevent an outbreak. So thank you very much.
Great, thank you so much, Ken. I had a couple quick questions for you, if you don't mind.
If anybody has one, sure.
If I can start, I had two thoughts. One is you talked about climate variability and the risk for disease, but has your group looked at climate change and what that's going to do to future risk?
We have, and we have it in two ways. We've done it for looking at how it will impact the mosquito vector in terms of spatial distribution, and we've also looked at it in terms of some of the linkage factors for particular diseases. So, and I can't give you a straight answer on that because it depends on where you're talking about what the impact will be. In some places, there likely will be increased transmission, but in other places, likely decreased transmission. But one thing that we've been observing in the last few slides that I just showed are that habitats are now becoming more suitable for some of these important vectors like Aedes aegypti in the United States and other places. So that certainly is not good.
Great. And my other question was about the animal vaccination program that you mentioned in Kenya that was so effective. Did the Kenyan government get some feedback as to that after that the outbreak was avoided?
By feedback? About
the effectiveness of their vaccination program?
Oh, yeah. So they completely on their own, with the exception of the U.S. mission there in Kenya promoted this based on our warnings. They did this without any additional aid, without any international support. They produced the vaccine in country and administrated it in country, and they were of course very happy, and needless to say, the farmers were very happy. And one thing I didn't mention is that when an outbreak like this happens, the OIE and FAO puts an embargo on any export of animals from that area. So it causes great economic harm as well as human and animal suffering.
Thanks.
Thank you.
Is there another question from the room? Great. So our next speaker will be my colleague Radina Soebiyanto from NASA Goddard.
Thank you. My name is Radina Soebiyanto, and I'm with a University Space Research Association stationed at NASA Goddard in Maryland. Today I will be talking about our project where we develop a web-based app to map and forecast chikungunya for the Department of Defense based on the association of the disease with climate and environment. So just to give you a brief description of chikungunya, it is a mosquito-borne viral infection. It was first described in an outbreak in southern Tanzania in 1952. Some of the symptoms include fever and severe joint pains that may cause stoop posture. Chikungunya itself means to be contorted, which describes the stoop posture of the sufferers. Some of the symptoms, sometimes the patients also present rash, which distinguish it from dengue. It rarely causes death, but it can be debilitating. And currently, there's no vaccine or specific medication to prevent chikungunya. And of course, because of this debilitating nature, there's implication for lost man hours because of sickness. And economic impacts, it can hurt tourism, especially during epidemics. The disease is commonly carried by mosquitoes, Aedes mosquito, the Aedes aegypti, and Albopictus. And they usually breed inside a water container. It can be in a flower pot, or inside the tires, or inside the tree where there's standing water, and also water fountain surrounding the houses. Before 2012, chikungunya, or around 2012 and before, chikungunya can be found in Africa and also in Asia, Southeast Asia. But in 2013, chikungunya emerged in the Americas. It started in St. Martin Island in December 2013, and this is when the first local transmission was reported. Within 8 months, chikungunya spread to 33 countries and territories. And by 2015, there are local cases of chikungunya in all of Americas, including the United States, in Texas and Florida, and also all Latin America, except in Chile and Uruguay. So because of this rapid spread of chikungunya in Americas, it really highlights the importance of readiness in assessing potential risk of vector-borne diseases. So this really called for a system or a framework to be able to monitor vector-borne diseases. And to address this issue, we developed our Chikkers app, and we hope that it can monitor chikungunya in a timely manner, and it will address questions such as where has chikungunya activity occurred, where is it occurring now, and which regions are currently or potentially at risk for chikungunya. So this is just an overview of the app. We have our chikungunya outbreak data and ancillary data such as population, elevation, and then we also have climate data, and we have our analytical engine, and this is where we develop our risk model to produce the risk map. And all of this needs to be converted to a specific format to be able to be visualized in our app. And our app itself sits on BSV, which is a DoD framework for this type of app. And then the users, what they call analytics, will be able to visualize the map and also the chikungunya outbreak data. And I will talk more about this later. So how do we do this? So first, we collect chikungunya historical data from publicly available sources. Our main sources is ProMed Mail, but we also look into Pan American Health Organization data, which is part of WHO, the World Health Organization, and we also look into data from the DoD itself. So if you're not familiar with ProMed Mail, so this is a system where it gives you alert for different kind of disease. So in that box, it's just a sample that shows the alert in that day for different type of diseases. And then we can extract the disease data, and then we will get this type of reports. And if I zoom it in, for example, it says Costa Rica in March 4th, there's about 1,100 cases, and then it tells you what provinces are affected. And sometimes they specify even up to hospital level, and then we georeference the data to the closest location, and we put it into our database where we record the location, how many people are affected, and we distinguish if there's any information about local cases versus imported cases, and then when is it occurring, and is there a time period, the time period it's occurring. And then finally, we map the chikungunya outbreak globally. The next one, of course, we have the climate and ancillary data. Currently, we have rainfall and land surface temperature in our app available for visualization. And this is because our risk map is currently based on land surface temperature and population. But we are working on looking into the association between chikungunya and other variables, including near surface temperature from GLDAS data, and then we will also look into specific humidity, vegetation index, and elevation. So how do we produce the risk map? In the first phase of our project, we just closed in our year 1 stage. Our goal is to produce a risk map for Latin America above equator. We chose this because this is when the chikungunya outbreak emerged the first time. So we asked ourselves, what are the climate conditions when chikungunya first appeared in the Americas? And to do this, we selected location where chikungunya was first reported in each country. And then we assessed the land surface temperature and precipitation condition at those locations. So this is one of the results. We use monthly modest LSD, and we use the 3-month LSD average prior to and during the month that chikungunya outbreak were first reported in each country. The plot shows the distribution of the land surface temperature anomaly when the outbreak occurred at those locations. The red line shows the time that the outbreak occurred, and the gray line shows for any other year. So you can see in here for Caribbean, there's a slight shift to the higher than normal LSD, and then in Central America, the distribution shifted quite visibly, and then in South America, even though the mean looks pretty much similar, but then there's a higher distribution at the right end tail. And if I counted how many locations have a positive anomaly, we see a pattern across a uniform pattern across the region. So in Caribbean, about 60 to 40% cutoff, and Central America, 75% of the location have higher than normal LSD and 25% lower than normal LSD, and also in South America. We also inspect the different lags, and what we see is similar pattern across the region, that land surface temperature is higher than any other year when chikungunya occurred. Next one, and this is just to give you an idea of the spatial distribution of LSD anomaly. So for example, for Caribbean here, for Caribbean, the first chikungunya outbreak occurred in December. So this is September and October, November, and you see in here where chikungunya first occurred, you see higher than normal LSD, and then also October and November, December, January. Same with Central America, it started in July, so during April, May, and June, most of the areas have a higher than normal LSD in this region, and also during the outbreak. However, when we look into precipitation, we don't see any uniform pattern. So we use the CPC unified data, and this is 3-month precipitation accumulation prior to and during the month that chikungunya outbreaks occurred. So in the Caribbean, we see similar distribution. Central America, we see weather condition, whereas South America, we see a little shift to the drier condition. So again, when we count how many locations have weather condition during chikungunya outbreak, the Caribbean and South America has the same pattern, but Central America has different pattern. And this is just to show you the different lags of precipitation, which the conclusion is the same, that we can't have a uniform pattern across the region. And so again, this is, as you see, rainfall anomaly is drier in the Caribbean, but in Central America, they have weather condition during chikungunya outbreak time. So based on that, we use land surface temperature and population to derive our risk map. At this stage, we only use a simple heuristic algorithm where we set a cutoff that higher than normal LSD would be a risk area. And we also did the same thing with population, where we profile the locations of chikungunya outbreak, and then we see that the population cluster in the higher density areas. So using these two data, we derive our risk map. Once we have this, we implement our analytics and also our maps in the app. So this needs to be in a specific format. So for raster layer, we have to put it in PNG, and then we have what we call map tiling. So this is just to enable the efficient zooming in and zooming out of the user, and to be able to move up and down, left and right efficiently. So basically the data will fetch whatever zoom level. So we divide the data. First we have the data at level 1, and then we divide it into 4, and we produce a 4 PNG data set. And if the user is zooming into, let's say, the area in the second tile, we fetch the correct tiles so that the user can zoom it in without losing the resolution. And for the historical data and polygon, we have to convert it into GeoJSON format to be able to, for visualization. And then we have what we call essentially the HTML map container, where you have layers of our chikungunya point data, the administrative level, and the climate data and population as the background. So this is a screenshot of our app, and this is the landing page. The circles indicates the outbreak location, and the number shows how many locations are in that position. Because we're at the zoom level 0, so we only see 1 point, but if you zoom it in, you can see there's actually 8 points that's closely located to each other. And for this one, the background is a land surface temperature anomaly. We have the option of showing the actual values and also the anomaly for LSD and precipitation. And then we also have on the top the option for looking into the outbreak data for different year and month. And then we also distinguish between local and imported cases. And this is for precipitation anomaly. And then lastly is and this is the risk map. And then if you click on any of the points, you will get time series of chikungunya outbreak for the country, for the specific country that you clicked in. And of course, you can overlay this with some administrative boundary, and I think currently we have up to district level. So in summary, this project has demonstrated the usefulness of remote sensing data in public health. So in particular, it provides a means for systematic monitoring and mapping of infectious disease outbreak. So there's a lag time between initiating climate condition and disease outbreaks. So this allows us to produce early warning system, which can aid public health decision makers in prevention and preparedness efforts. To summarize the challenges in this project is, of course, the availability and accuracy of the outbreak data. Our main source is currently from publicly available sources, and this is just like a passive surveillance system. We cannot validate the actual number of cases, and there's no consistent baseline disease outbreak records. And also, modeling chikungunya in a naive environment presents a challenge because most of the population doesn't have never been exposed to the disease, so no one has the immunity. But throughout time, the disease dynamics will change because some people will have immunity and so on. And of course, it requires interdisciplinary team from data analysts, climate and remote sensing scientists, public health professionals, entomologists, and computer scientists. In the next phase, we will expand our risk mapping to global level. And then we also plan to use more recent data and other variables in the model. So lastly, I'd like to thank our team members, the PIs, Asaf and Yamba, and our web developers, Zafar and Shivam, and our graduate intern who collect the data, Raike, and of course, our advisor, Ken Linthicum. And this project is supported by the DoD, the Defense Threat Reduction Agencies. Thank you.
Thanks, Radina. I think there's time for one question from the room.
Hi, thanks for the good presentation. So you kind of touched a little bit at the end, but in terms of your risk mapping, I mean, the most important things are whether the mosquito is there, and then the level of susceptibility in the population, you know, how many of them are immune already. And it doesn't seem like you're including either of those things in the risk mapping. Is that something you're trying to add, or?
Yes, that's something that we will add, because in order to put the immune system and the immunity and the susceptibility, we will need a dynamical model, such as the compartmental model, and we're looking into finding a good time series data, even though it's at country level, which is usually available in country level. So yes, that's something that we're going to look into.
Oh, thanks.
Hello, Radina. It's a very good talk. Yeah. Since you are working at Goddard, and I think we briefly talked about it yesterday, probably, I think the data, the global one, also the timely one, certainly you probably would like to work with some data center in terms of data collection. I'm not sure if that could be a good approach.
Yes, I think it will be. I think it will be good. I mean, well, being at Goddard, so it's very accessible to me. But I think in terms of the public health professionals, they're very interested in getting climate data, environmental data, and they don't necessarily have the experience in using this data set. So I think it will be good.
All right, thank you.
Thanks, Radina. So we're going to switch gears to talking about the health impacts of air pollution. And our next speaker is Yuqiang.
Hello, everyone. First of all, I'd like to thank Maggie and all other conveners for attending, for organizing and having me for this session. And also, I want to thank all the people who are attending this session. There are more people than expected. Second of all, I want to acknowledge all my co-authors for their contributions to this work. I'm Yuqiang Zhang, a postdoc researcher at US EPA. This is a disclaimer for this presentation. I think you will see this very often. I assume a lot of people in this room know that there are connections between the ambient air pollution and human health. For example, a recent study, a recent global burden disease study by Cohen et al., they estimated that in 2015, in US, there will be like almost 90,000 deaths associated with ambient PM 2.5 concentration, ambient PM 2.5. And for ozone, there will be almost like 12,000 deaths associated with ozone. So in total, that accounts for that ambient air pollution can account for 1 in 26 US deaths in the US. So a few months ago, EPA just released the report called the US EPA air quality trends. So in this report, they released the trends for the major air pollutants, including PM25 and ozone, and also other pollutants. So from this table, from this plot, we see that for the ambient PM25, the annual PM decreases by 42% from 2000 to 2016. And for the maximum daily 8-hour average ozone decreased by 8%. So we asked the question, so what are the trends in air pollution mortality due to the changes in air pollution changes? So the major objective for our study is to quantify the annual mortality burdens of ambient PM and ozone in US from 1990 to 2010, based on the long-term model simulations. And then we analyze the contributions of the changes in air pollutants, the baseline mortality, and also the population changes in the overall trend. There are several innovations in our study. First of all, in this study, we estimated the mortality burden by using the annual county-level baseline mortality rate and also the county-level annual population data. And then we have these innovations in analyzing the interannual variabilities of the mortality. This is model simulations we carry out for this study. There are some key features from this model. For example, we use the coupled wolf sigma model running at 36 times 36 kilometers and using self-consistent emission inventory in US. For the other configurations, I will suggest you to look at the paper published in 2016, which has very detailed information. And for the health impact analysis, we use this health impact function. And like I mentioned earlier, in this presentation, in this work, we take advantage of the county level baseline mortality rate by calculating the individual county from the CDC website, including the annual baseline mortality rate and the population. And then we regrade them to the 36 grades to be consistent with our model outputs. And then for the attributed fractions, for PM, we use integrated exposure response. And for ozone, we use a log linear model from JiaBin et al. In 2009. Model results. So this plot shows the air quality in 1990 on the left, in 2010 in the middle, and also the trend for the past 2 decades from 1990 to 2010 on the right. For PM on the top and for ozone on the bottom. The take-home message from this slide is that if you look at the plot on the right, we found for both PM and ozone, they have greater decreases over the east, smaller decrease or even slight increase over the west. For the trend figures on the right, you see the gray colors. It means the trend, either for the decrease or increasing, they are not significant based on the standard two-tailed of the student t-test. Then we estimated the pattern, the trend of the annual PM and also sample time average of a daily maximum 1 hour ozone with 2 metrics for the population weighted average in right and for the regional average, the US domain average in black. So we found that in US, for PM25, the population weighted average have decreased by 39%. And for the domain average, it decreased by 29%. For ozone, it decreased by 9% for both of these 2 metrics. And we concluded that both the PM and ozone were attributed to the significant emission reductions for their decreases. Then we estimated the annual mortality burden based on the data I just talked about it. So for the annual mortality burden, it shows here in black lines, as well as the error bars showing for the 95% confidence interval. So we concluded that for the PM mortality burden, it had decreased by 53% from 123,000 deaths per year in 1990 to 58,000 deaths per year in 2010. And then we did some sensitivity analysis by accounting for concentrations only, which is showing in the blue lines, as well as we didn't account for any percent change at all from 1990, which is showing in the red lines. So the conclusion we draw from these two sensitivity analysis is that we found without the decreases of the PM since 1990, the mortality burdens would only decrease by 24%. As well, if we consider the PM 200 changes only, and we didn't account for the population as well as the baseline mortality changes, we found that the PM reductions since 1990 could reduce death in 2010 by about 45,000 deaths. That's about 36% of the total. And then this is a similar plot for ozone, and we found that for the ozone mortality, it actually increased by 13% from almost 11,000 deaths per year in 1990 to 12,000 deaths in 2010. And with the same sensitivity analysis, we found that without the decrease in ozone, however, the burden would increase by 55%. And also, by looking at the red lines, we found that for the ozone reductions since 1990, it has decreased death in 2010 by about 3,000 deaths. Then we calculated the relative mortality burden changes at city level for both PM2.5 and ozone from 1990 to 2010. So the difference is calculated as values in 2010 minus 1990 divided by the 1990. So you can see that I use the same color bar, but they have different legend. For PM, since for all the PM-related mortality burdens, they have been decreasing all of the US. So for the colors in blue, it means the decreasing trend is larger, relatively. And for the colors in red, it means the PM burden changes are relatively smaller. And for ozone, since there are some increases and decreases for the mortality burden associated with ozone in US. So for the colors in blue, it means the ozone mortality burden will decrease in this state. And for the color in red, it means the ozone mortality burden in this state will increase. So the major conclusion we draw from this slide is that we found for PM25, for the relative mortality burden changes, we see relatively larger decreases over the over the Western US, and we attribute it to the smaller PM mortality burdens of these states. And for ozone, we found that for the western of the US, the ozone mortality burden is increasing, while for the northeast of the US, they are decreasing. Then we compared our study with like literature availables, and this is a comparison between our study, which is shown in black, with other studies for PM on the left and with ozone on the right. So the conclusion we draw from the comparison is that we found our mortality burdens we estimated in our study are comparable to previous studies. However, if you take a look at the mortality burden for PM on the left, we see that our estimated decreasing trend is comparable to fine et al., which is showing the green colors, which was just published a few weeks ago on the Journal of the Environmental Health Perspective. But the trend, the decreasing trend from these two studies are greater than Cohen et al. Probably a few months ago. And we concluded that our study may have overestimated the decreasing trend relative to the observations. And for ozone, on the right, we see that our results for the ozone mortality burden trends are comparable to the previous studies. Then, by working with our coworkers, we have been able to extending our results to 2015 by taking advantage of the North American Chemical Renaissance Project. We call it NACR. So for this project, they have been using the CMAC air quality forecast simulations, using the data assimilation of the OMI and MODIS satellite observations. So we have calculated the mortality burden from using the data set from 2009 to 2015 for both PM and ozone, which is shown in the red colors. And we draw the conclusion that we found the mortality based on this project agrees very well with our model results. And also, if we take a look at the ozone mortality burdens, we found that the ozone mortality may have peaked in 1998. The major conclusion we draw from this study, we found that the PM 2.5 mortality burden decreased by 53%, reflecting the decrease of the PM 2.5 concentrations as well as baseline mortality. And also, we found that the concentration changes alone could decrease the mortality burden by 36%. For ozone, we found that the mortality burden increased by 13%. Mainly caused by the increase of the baseline mortality rates and the population changes. And the concentration alone could decrease the mortality burden by 25%. And I thank for the my fellowship and also the funding sources from NASA as well as funding sources from China. Thanks.
Thanks so much, Yuqiang. I guess I'll ask the reverse question I asked before. So you were looking at longer-term trends. Can you attribute changes in mortality and deaths to specific events? For example, the wildfires that are happening in California, I imagine, are having health impacts.
Sorry, can you repeat?
The current wildfires in California, I imagine, are having health impacts. So are you able to attribute changes in mortality to specific case studies?
I think by using the annually data set from the CDC, we can account for that. For the I mean, another reason why we use a county level baseline mortality rate because from a recent paper we found that there are very large differences between for the special patterns of the baseline mortality rate for different diseases. So I think that it could be by using this fine levels of data, it could be accounting for the anomalies of the diseases caused by natural sources like wildfire or others. Yeah.
Great, thanks again.
Mm-hmm. Thanks.
Great, so our last speaker is Qingyang Xiao.
Hello, everyone. So I'm Qingyang Xiao from Emory University. Today, I'm glad to present my study entitled The Association Between Birth Outcomes and Satellite Estimated Maternal PM 2.5 Exposure in Shanghai, China. So first, let me introduce PM 2.5. PM 2.5 is fine particulate matter with an aerodynamic diameter of 2.5 micrometer or less. This very small particulate matter can go deeply into our respiratory system and leading to various adverse health consequences, including respiratory disease, cardiovascular disease, and lung cancer. The 2015 Global Burden of Disease study identified PM 2.5 as the fifth largest overall risk for global mortality. Previous studies also support the link between maternal PM2.5 exposure and adverse birth outcomes. It is estimated that PM2.5 exposure is responsible for about 3 million preterm births in 2010. The health effect of PM2.5 exposure has been widely studied in the US, but few studies were conducted in highly polluted regions like China due to the lack of historical PM2.5 measurement. In China, the National Air Quality Monitoring Measurement was established in 2013, and we have no reliable national monitoring of PM2.5 before that. Thus, satellite aerosol optical depth, or AOD, has been increasingly used for air pollution exposure assessment. Satellite data with global coverage, high spatial resolution, and long data record can extend the ground air quality monitoring network spatially and temporally. However, satellite data also has some limitations. One is the missing data due to cloud cover or high surface reflectance. Cloud cover affects the production and deposition of AOD. Thus, this missingness is non-random and may bias our exposure assessment. So we designed this project, and the objectives of this a previous study analyzed the influence of missing satellite data on estimated short-term health effects of PM2.5. And the researcher reported that when assessing regional average PM2.5 exposures, missing satellite data tended to overestimate PM2.5 exposure, and removal of subjects with missing satellite data led to a smaller sample size. However, the influence of missing satellite data on estimated long-term health effects of PM2.5 is still not clear. Thus, we designed this study, and the objectives of this study is to first analyze the associations between birth outcomes and maternal PM2.5 concentrations in Shanghai, China. And second, to compare estimated health associations across 3 exposure matrices from central set measurement, gap field satellite predictions, and satellite predictions with missingness. By comparing the health effects estimated from the first 2 exposure matrices, we can analyze the benefit of using satellite data in exposure assessment. And by analyzing the health effects from the second 2 exposure matrices, we can have the estimate of the effects of missing data. So this is our study domain in Shanghai. Shanghai is located on the east coast of China. Shanghai is one of the largest cities around the world with over 24 million residents. This map shows the spatial distribution of our study population in Shanghai, and the darker blue indicates more people living in this region. There are 10 ground monitoring stations in Shanghai, shown in red dot, but 8 of them are clustered in a small region. Thus, measurements from these monitors may not represent the exposure level of people living in southern part. Shanghai is also affected by monsoon in summer, with weeks of rainy and cloudy weather. Cloud cover leads to up to 75% missing data. Since there are more missing data in summer when the air pollution level is relatively low, this missingness is non-random. And for the exposure assessment, we designed 4 exposure windows for doing each of the 3 trimesters of the pregnancy and the entire pregnancy time period. Exposures were assigned by maternal residency and averaged across each exposure window. To assess the exposure level from ground PM2.5 measurements, we downloaded the hourly measurements from PM25 in and removed continuous identical measurements. Since these monitors are clustered, we use the daily regional average concentrations to estimate exposure level. And to estimate PM2.5 exposure level from satellite predictions, we design a 2-stage method. First, we fill in the missing AOD in satellite data using multiple imputation, and then we predict PM2.5 concentrations from the gap field's AOD. So in the gap filling stage, we fitted a daily additive imputation model using the spatial autocorrelation of AOD, the cloud friction, the CMAC simulation, and also meteorological and elevation parameters. In the PM2.5 prediction stage, we first fitted a linear mixed effects model with daily random effect of AOD, and then we use a generalized additive model to model the residue of the linear mixed effect model using land use information. So after gut filling, the coverage of satellite retrievals increased from below 40% to 100%. And this two density plot shows the performance of monthly average PM2.5 predictions with and without gut filling. A different color indicates different numbers of points within each grid cell. And as shows here, we can see that after gut filling, the R-square compared with ground measurement increased from 0.84 to 0.92. And also, we have decreased root mean square error and the percentage prediction error. Thus, we conclude that our gut filling method corrected the exposure bias due to missing data in satellite. And this map shows the annual average PM2.5 predictions at 1 kilometer resolution in 2014. First, we noticed that our prediction matched well with ground measurement, but the satellite prediction revealed much more spatial variation in PM2.5 concentrations. And also, we noticed that the PM2.5 exposure level in Shanghai were much higher than previously studied regions. Previous study in the US reported that the mean pregnancy exposure level ranged between 10 to 19 microgram per cubic meter. But in Shanghai, we had the mean pregnancy exposure level at 60 microgram per cubic meter. And we obtained the birth registration data from Pudong area CDC, and we have 130,000 births in total. We have 3 interested outcomes. Preterm birth is defined as a birth with less than 37 weeks of gestation, and term low birth weight is defined as a full-term birth with birth weight less than 2.5 kilogram. And we also use birth weight as a continuous variable. And now I will talk about the statistical models we use to analyze the health effects. So we use linear regression to analyze the effect with birth weight. Here, the capital E represents the individual exposure level, and capital C represents the covariates we controlled in this study. We also control the long-term trend using a cubic spline with 1 node per year. And we use the logistic regression to analyze the association with term low birth weight. The estimated odds ratio per 1 unit increase in exposure level is estimated as the exponential of beta 1. Regarding preterm birth, for the health effect of exposure during the first and second trimester, we use logistic regression because we followed all the births during these 2 time windows. And we use discrete time survival model to analyze the association with third trimester and the inter-pregnancy exposure, because the health outcome affect these 2 exposure window, and the population at risk changed in time. So here, the YIT represents whether a birth happened during week T for pregnancy I, and also we have the time varying exposure level EIT, which is calculated as the average PM2.5 concentration from week 27 to week T for the third trimester exposure, and from week 1 to week T for the entire pregnancy exposure. Now, I can show some interesting results. So this figure shows the estimated health effects and 95% confidence interval of birth weight, preterm birth, and term low birth weight. Different color represent the health effects of exposure during different time windows. So first, we noticed that PM2.5 exposure during all time windows were associated with decreased term birth weight and increased risk of preterm birth. Comparing the health effects of Comparing the trimester-specific health effect, we noticed that the exposure during the first and the third trimester had a higher health effect for birth weight and term low birth weight. And exposures during the first trimester has higher health effect on preterm birth. We also noticed that the health effect estimated in this study are higher than previous findings. So this table summarizes the estimated odds ratio for preterm birth and term low birth weight in this study and in previous meta-analysis and studies in China. So in this study, we estimated higher value of odds ratio. We believe one reason could be that we use the high resolution satellite predictions for exposure assessment. Thus, we better describe the spatial variation in exposure level and reduce the exposure error. And this figure shows the comparison result across different exposure matrices using gut field satellite data with missingness, and ground measurement. We noticed that missingness in satellite data underestimated the health effects compared with those from gut field satellite data and ground measurements. We also noticed that the estimated effects using gut field satellite data had similar magnitude but tighter confidence interval rather than the ground-based exposure. And here, for the exposure, for the health effect of exposure during the inter-pregnancy, we noticed that the estimated using gut field satellite data is higher than those that estimated using the ground measurement. We believe that is because when averaging during a longer time period, like the inter-pregnancy, the spatial variation became more important, but the ground measurement may not truly reflect the spatial variation. And results from the preterm birth support the similar conclusions. So to summarize this study, first we observed adverse birth outcomes in association with maternal PM2.5 exposure in Shanghai. And we noticed that the magnitude of associations between maternal PM2.5 exposure and birth outcomes in this study was higher than previous findings. And one reason could be the reduced exposure error from satellite predictions. And we also find that the health association estimates was influenced by exposure assessment approaches. Missingness in satellite data can bias the estimated health effects, and the gut field satellite predictions are preferable when analyzing health effects of local scale varying exposures. And this is the end of my presentation. Now I'm open for questions. Thank you for your attention.
Thank you, Qingyang. Are there any questions from the room? If so, if you'd use the microphones here on the side. Okay, if not, we're going to go on to our panel discussion. So please give us a minute to get set up here, and we'll start with some questions for the speakers. Thanks. Great. Well, thank you to our audience here for staying for our panel discussion. The geo-health field is a focus of this meeting and now for AGU, and you can see that based on the size of the room that we have here today. So I just have some general questions for our speakers, and we're also joined by Dorian Janney, who's one of my colleagues at NASA Goddard, who's working on the Global Precipitation Mission and its disease initiative. So first off, you all discussed a lot of different climate and air quality data sets. Could you just tell us a bit about the types of data sets that you're using, both geophysical and also health data sets, and whether they're adequate for these type of public health studies? What are the advantages of these data sets, and what is lacking, and what could we work on in future both from remote sensing and also from the health sector. You want to start with?
Sure. So I guess for remote sensing data, we have land surface temperature and precipitation, and we're also looking into GLDAS data set for specific humidity and yes, near surface temperature, and then elevation and NDVI. And as for health data, we look into publicly available sources. So they're from ProMed, which is just giving us the lat-long location and also some of the number of the cases. And we also look into PAHO data, but that's at country level. So I guess one of the challenges would be to match the spatial resolution. Some of the data set, some of the health data are in country level, and then of course this will be adequate for remote sensing data, but if you just have a point, and some of the precipitation data sets are quite low resolution. So, and then we're not sure whether our study that we're not finding any relationship with our precipitation could be due to the low resolution of the precipitation data that we use.
From our perspective, we have a wide array of data products that are useful for our vector-borne disease studies. However, I would echo Radina's comments that increased spatial resolution is important, would be nice, but most importantly, perhaps, would be increased temporal resolution. And then I would say that compared to the entomological or health data that we have available, the physical Earth data sets are much more robust. We need to generate better biological data sets.
For air pollution, specifically for PM 2.5, we use satellite AOD retrievals, so that can be from different sensors. So currently we have the MAYAC, that is a very high resolution data set at 1 kilometer resolution, and we have standard like modest 10 kilometer resolution data. We also have like the GOSI, which is a geostationary satellite, so that provides the 8 observations per day, so that is improved temporal resolution. And we also use some other remote sensing data set for us to develop the prediction model, like the cloud friction, also from models.
So from my point of view, I mean, I have been using the modeling data a lot. So recently, I think with the data fusion of the satellite and surface observation, so I think with like incorporating these three, it will be potentially greatly improve the accuracy of our estimation of the PM, surface PM, and it will greatly help us to like estimate the PM-related mortality burdens. So I think there are several products like Zhang said, and I think it would be beneficial if we can combine these two and get an ensemble model. Ensemble product means. So. Yeah.
Any more comments?
Well, I specifically work with the Global Precipitation Measurement Mission. We launched in 2014 and have been collecting precipitation data continually since 1997 using a different mission, the Tropical Rainfall Measurement Mission. At the present time, we have not yet completely been able to align the TRIM data from 1997 to seamlessly be the same product as we're looking at with our GPM data sets, but hopefully by May 2018, this coming May, we will have taken care of that. At that point in time, with this mission, we have a spatial resolution of about 10 kilometers, and we have a temporal resolution of every 30 minutes, and that is globally.
Thanks, Dorian. So another tool that was mentioned a lot were models, and Those range from numerical climate models to composition models, and also some of you are using more statistical models to link health risks to climate and atmospheric variability. So could you tell us, just those who want to comment, how do those tools help you make those links, and what's still missing from those models where we could work in terms of future research?
Yeah, I have been using the numerical model a lot, so I think from my point of view, so they are still lack of the implementing the new mechanisms of the chemical species. For example, like the new mechanisms of the secondary organic aerosol into the new chemical transport models. So it makes like our model performs less. Not very good compared with subtle observation. So I think that's like kind of the field a lot of scientists have been working on. Also to like overcome that dependency, I think by working on the diffusion of the surface and satellite, it will also help to have the models to predict the major air pollutants. So.
And previously, we used lots of statistical model for the PM2.5 prediction, and actually various type of statistical model has been present. But currently, more and more study groups are trying to use the machine learning algorithms in the PM2.5 prediction, because we already know that the relationship between PM2.5 and AOD is very complex and nonlinear. So the machine learning model may be like a future study field for us to improve the model performance and increase model resolution.
Great, thank you, great comments. So in terms of weather and climate, what do you think are the most pressing health concerns from extreme weather like floods and droughts and hurricanes, and also from climate change that you see in your work?
Well, of immediate impact, of course, are the extreme events, and extreme events we can see immediate consequences, but in the long term, we need to prepare policymakers to be ready to respond. And so I think ultimately it's the longer term events that we need to worry about most.
Yeah, I think probably just to add that for maybe hurricanes or flooding, sometimes the effect especially for vector-borne diseases, are in the year after the event, where mosquito population will increase even more. So that's something that public health professionals needs to be aware of.
I think this is a really exciting time in our history, because we're able to now use these Earth-observing satellite data sets. We've got some wonderful case examples, as we've heard here, for ways that we can take this remote sensing data and use it as a proxy for places that don't have the ability to collect this environmental data. And most certainly we're seeing that globalization is leading to the spread, as we learned with the Chikungunya story, and you'll hear the same thing with other vector-borne and water-related disease, particularly the vector-borne disease. Climate change is most definitely going to have an impact on the spread of many of these vectors and the suitability for them. So by having, exactly as Kenneth alluded to, having public officials involved, and also helping our operational end users know that these data sets are freely available to them to be exploited and used so that they can anticipate and respond effectively.
Yeah, actually I want to add that I have been interested to look at the impact of the climate change, for example, the climate change could affect the temperature and precipitation, and then it will affect the air pollution. So it's kind of the indirectly effect of the climate changes. So I think that's also another area I'm very interested to look at.
Okay, so there are a few topics that my co-conveners and I identified that you didn't really talk about in your case studies today. And those included wildfires in the western US that I mentioned, and I guess other natural hazards, dust storms, some emerging vector-borne disease. Zika was discussed a little bit, as well as Lyme disease, and also the links to sanitation or areas where there's lack of formal infrastructure there. Do any of you work in those areas, and would you like to comment a bit about your work?
So I'd like to talk about like wildfire, because most of the wildfire cannot be caught by the ground monitors because they are in the remote region. And using satellite, we have one issue is that not currently the satellite data is it's polar orbit, it's on the polar orbit, so it has like one observation per day. So that is not, the temporal resolution is too low to characterize the wildfire. So, but in the future, there will be more like satellites as a geostationary satellites. So that it will give us more observation per day. So it can better describe the production and the development of wildfire, and it also is health effect and like effects on air pollution.
And I know that Dr. Antar Jutla out of West Virginia University, at this conference, he told about some of the results that he has had in being able to predict the outbreak of cholera, both in areas where they're experiencing conflicts, such as recently he was able to use environmental satellite data sets and predict, and in addition to some other types of more behavioral and political data, and predict the outbreak of cholera in Yemen. And before that, he had used some data related to a hurricane, and had predicted a cholera outbreak, which indeed did occur in the areas in which they had pinpointed in Haiti during Hurricane Matthew. So I think there's some very, these lead to some very good possibilities for being able to use environmental data to be able to anticipate the onset of waterborne diseases such as cholera.
Yeah, that's great to hear about. I think we've already come a long way, and this discipline is still pretty new. So the other thing that we wanted to address was our links to agriculture and nutrition. For example, if there's a drought, then that's going to affect crop health and eventually nutrition and leading to disease, and the same for air pollution. Really, if there's a lot of pollution, that's going to affect crops and health in general, and then leading to disease. Have any of you looked at those aspects or see your work going there in the future?
Well, from an agricultural point of view, we've looked at animal disease, animal available as a food source, also animals as food safety issues. Obviously, when diseases are introduced or are enhanced, those are important issues. Diseases like what I talked about, Rift Valley fever, as an animal disease, should it be introduced into new areas like into the US, it would cause great havoc, both in terms of food availability and food safety, just like it does in endemic areas where food prices skyrocket when an outbreak happens and people starve because they can't have enough food available. Thank you.
I want to add that one of the research direction have been developed during my postdoc research is that I've been looking at the depositions of the nitrogen and also its effect on the ecosystems. So what we found is that for the modeling part, they have been greatly underestimated the deposition trend and also the magnitude of the deposition, largely because we have been unable to establish and also build a very accurate ammonia inventories, which most come from the agriculture. So I think by working my future research, I have been thinking to using the satellite data simulations or retrieval data to build a top-down emission inventories for the ammonia and put them into the modeling part, and then explore how the adaptation will affect agriculture and also other ecosystem aspects. Thanks.
And I'll just add, I know one of the applications of the Global Precipitation Measurement Mission data, it is being used, I believe it is in Pakistan, by government officials. They will send to farmers a text message based on they're looking at the GPM precipitation data, and the text message will let the farmers know whether or not they should water their crops or not, and that way they're able to conserve more of their freshwater resources.
Great, thank you, Dorian. So the last question for me is imagine that we're having this session in 5 or 10 years. What do you expect would be the topics that we'd be discussing, and what would you in particular like to be talking about then? How do you see the connections between geoscience and public health evolving? So let's just go down the line.
Well, thank you very much, Maggie. We started in this line of research about 40 years ago, and at that time, very few people were making that connection between geoscience, environment, and health. And it's been really remarkable to see the advancement in that connection, and I would anticipate that will grow logarithmically, increase.
I'm hoping in the 5-10 years, with the public health data will be more available and routinely collected. So we're all going to have a risk map for most of the infectious diseases, and we can will be prevented timely manner.
The disease initiative that I am working with, our overall goal for the next year is to be bringing together the different stakeholders that Radina had presented in her slide, bringing together our operational end users, our government officials, research scientists both in the fields of epidemiology, entomology, as well as remote sensing, and remembering to include our computer programmers, data analysts, and then finally we also want to include our general public, because often it is the small measures that the general public can take, especially in ensuring that they do not unwittingly provide vector breeding grounds, and also that they take the proper safety precautions. So my hope is that by bringing together these interdisciplinary teams, we can work on having the data sets more easily accessible to our operational end users. Those of us who work on the satellite side can work on doing things such as being able to utilize the technology to decrease the, or actually to increase the spatial resolution. So instead of a 10-kilometer swath, being able to predict how much precipitation is falling, perhaps we'll be able to get to something, a finer resolution. So that's kind of what I hope and foresee.
Yeah, I think recently there have been like increasing demand for the collaboration work between the geoscience and the public health, and especially like in like the air pollution views, we have been like relying on the satellite data and survey data to get the data fusion and get accurate model applications and get the accurate inventories. And I think that we have more help for the like animal science or even public health communities to more do their studies. I think that trend will be still like going on in the next few years. Yeah.
So I think the development in technology will definitely improve the development of the geo-health. Because I remember when I first downloaded the satellite data, we have only MODIS collection 5 data, so that's at 10-kilometer resolution. And then we have MODIS satellite collection 6, that has 2 like deep blue and target AOD, and also has a 3-kilometer resolution product. And also we have GOSI and more different sensors and different data sets. And also for the analysis tools, now we have the better computer, we have the cloud, and we have like powerful algorithm like the machine learning. So I think all this together, we will have like better understand theirs and its relation with health.
Thank you all. So the recurring themes there were just the openness and accessibility of data and new tools like machine learning and hopefully higher resolution data sets in particular for health, but also for the geosciences. So are there any remaining questions from the room? And if so, could you please use the microphone there in the center?
Hi, thanks for the discussion. So you talked a lot about the geoscience like data sets, but I was wondering if you could comment on like the public health data sets, if they're available, about mortality rates for diseases or particulate matter, where someone could go to look for those.
Great, thanks.
Sorry, can you repeat the question again?
Yeah, sorry. So it seems, this isn't my field, but it seems like you're using data sets like PM 2.5 and linking it to health, but where do you get the health information data? Where do you get like the number of deaths from that are related due to respiratory diseases and things like that?
Okay, yeah. So I think the data are publicly available on the US CDC website, and I think back to several decades ago. So yeah, I mean, we basically have the data at the county level. So at a different age, like gender-specific, something like that. So you can download them and process from there. So yeah, thanks. Mm-hmm.
And actually, I think we need more collaboration between like the people who have the health data and other like the geohealth analysis, because sharing data is still a big issue here. It's not easy to get the health data from China. And I can understand there's some, the personal information issues, but I still hope we can have like a more open data set sharing system.
Great, that's another aspect of this field, are the sort of partnerships with the local end users. Any further questions? If not, I'd just like to thank all of our panelists today for their great examples of connecting health outcomes to geospatial data. So thanks so much.
You're welcome.